Good morning to one and all present here. My paper is on box inscription, CLAU, graft tucking and autologous blood, best friends for a pterygium novice. So I'd like to acknowledge my co-author Dr. Shruti Vaishali Ramesh at this juncture. So pterygium is a very common ocular pathology that is encountered in clinical practice. Microsurgical training is an important tenet to be established during ophthalmology residency, and pterygium surgery will be a good starting point because of the high rates of pterygium, straightforward and extraocular nature of the surgery, and lack of necessity for any advanced technique or equipment. So pterygium excision with CLAU is the first surgery that is taught to postgraduates in our institute because of the high efficacy and safety of the technique. So in this technique, there are certain impediments that we face, that is inadequate graft size, buttonholing of the graft, insufficient removal of tenons, difficulty in preparation of the graft bed, difficulty in appropriate orientation of the graft, and loss of the graft. So in order to overcome this, we have added certain nuances to the pre-existing technique, and we have assessed its efficacy in the hands of such training surgeons. So the aim of the study is to assess the efficacy of pterygium excision using a nuanced approach of conjunctival limbal autografting, which is the sutureless, glueless, box inscription and graft tuck-in method when done by first-year surgeons in terms of retention, recurrence and post-operative complication rates. So coming to materials and methods, it was a retrospective study done over 200 patients over a 6-month period. We initially graded the pterygium based on the distance from the limbus, and nasal and temporal encroachment was called a double pterygium. So selection criteria included patients with grade 2 and more pterygium, and we excluded patients having recurrent pterygiums, glaucoma specs, symplepharon and limitation of ocular movements. So coming to the technique, the first part is to excise the pterygium. So we give a nick in the neck of the pterygium, and we remove the pterygium at the neck. The pterygium head is then removed from the cornea by using a reverse stripping method using a toothed forceps, and the remnants are just scraped off. Then we prepare the graft that is needed by measuring the amount of graft that is needed using calipers and marking it on the superior bulbar conjunctiva. We dissect the tenons using a dual technique. First, we do a subconjunctival saline injection to create a cleavage plane, and then through the cleavage plane, we do a blunt dissection using scissors. A good cleavage will be indicated by the clear view of the scissors through the conjunctiva, which is shown in the video. Following the dissection, the graft is then excised. First, the distal part of the graft is excised, and then the proximal part, we ensure that a thin rim of the corneal epithelium is included so that stem cells can be included. Then, without lifting the graft, we just drag the graft in place into the bed, iron the graft, and then tuck it in properly in the conjunctival bed, and we allow the blood to ooze over the graft to act as an adhesive. So data was collected on intraoperative complications and on post-operative first and 6-month complications, and retention rates were collected. Data was analyzed using SPSS. So coming to the results, we had 200 patients with a mean age of 50 years with a female preponderance, and grade 2 was the most common pterygium we saw. The only intraoperative complication was buttonholing in 3 cases. A graft was retained in 197 cases. The most common post-operative complication was subconjunctival hemorrhage. We also had graft edema, Dellen, loss of graft, and graft encroachment. So coming to discussion part, so there was a female preponderance in our study with most of the patients belonging to 4th decade, and there was a gradual upward trend. So other techniques mainly failed. Mainly the conventional vascular technique had very high recurrence rate, mainly because of the corneal limbal stem cell deficiency. This we overcome with the help of the CLAU, which had the stem cells. We chose this method as the inaugural step in the microsurgical training because of the ease of the technique, and we added certain improvements to overcome common impediments. So we chose autologous blood as an adhesive because of the high graft retention rates and almost no complications because of the inert nature of using the patient's own blood. So the only intraoperative complication was just 3 cases of buttonholing. We were able to majorly avoid it because we injected the subconjunctival saline a little away from the inscribed site, and we used a blunt dissection technique. So graft retention rates was pretty high in our study because we added certain refinements like creating a proper pocket, ensuring that the graft size was adequate, and we even increased the graft size. We optimally removed the tenons tissue using a dual method, and we ensured that the graft did not get flipped by using the no lift technique. So only 3 cases of graft loss was encountered, mainly because of the inadequate graft coverage. Post-operative complications were trivial, the most common being subconjunctival hemorrhage. There was 1 case of recurrence, and the low recurrence is mainly because of the inclusion of the limbal stem cells in our graft. In view of the simplicity of this technique, it was expected to perform well in the hands of inexperienced surgeons, and the surgical outcomes speak for itself. So to conclude, microsurgical training is an important part of ophthalmology residency, and the pterygium surgery with the refinements that we have added will be a good starting point to be taught to the postgraduate residents. So the study found high graft retention rates, minimal intraoperative and postoperative complications, and almost no recurrence rates. So it implies the success of this technique as a good starting point to be learned by budding ophthalmologists. So these are my references. Thank you.
Yeah, a very quick comment.
Yes,
The process were very well documented. I take one exception to one step.
Yes, ma'am.
I will not recommend an epithelialized surface being tucked under another epithelialized surface.
Okay.
In a
Yes,
very
ma'am.
long term, you will have the problem of epithelial inclusion cyst.
Okay.
If you really want to do that,
Yes,
the
ma'am.
periphery of the conjunctival, the graft that you are taking should be de-epithelialized before tucking. That makes the surgery a little more complex.
Yes, ma'am.
Also, overriding is never a good idea in general terms of wound healing mechanism.
Yes, ma'am.
So the two things that it portends, the overriding as well as the inclusion of epithelial layer
Under
underneath
the
another
epithelial
epithelial layer, I take a little bit of objection.
Yes, ma'am.
You
Otherwise
should
it will
try
not.
to approximate.
Yes, ma'am.
When you try to approximate, it holds good even with your autologous blood. That's what we do routinely. So
Yes,
we just hold it. We have to hold it for a minute time.
Ma'am, we allow the autologous blood to act as an
No,
adhesive.
just hold the edges together.
Okay.
It will seal.
Okay.
You
It's
pinch
going
the
to seal.
edges
You
like she
pinch
said.
hold. You have just hold with this one and pinch it and keep it for a minute time. We're
Yes,
just going to hold
So
it.
basically, we wanted to have a very simple technique because it is all done by a
It's
person.
simple enough. The way she says is simple enough.
It's
If
very
you
simple
follow
enough,
up these
provided
patients
you
for 3
do
years,
it.
4 years, a couple of them will develop conjunctival inclusion cyst
Okay.
because the epithelium which you have tucked in has nowhere to go and it will start proliferating.
Yes, ma'am.
And it's very common to get an inclusion cyst.
Okay. Yes,
This
ma'am.
is one of the when we have an inclusion cyst, we think like this has gone under.
Okay. Yes, ma'am.
That's where we start thinking something is wrong, gone wrong.
Okay.